Now today we are going to discuss ischemic heart disease, or what's called coronary artery disease. Now basically the coronary artery disease is a demand and supply mismatch. When the myocardium, the oxygen demand or the nutrient demand starts increasing, if the blood supply does not match that demand, patient starts having symptoms of what is called ischemic heart disease. Now the ischemic heart disease, before we start on to what is ischemic heart disease, we see a little bit about the coronary circulation. The coronary circulation is peculiar in some way. It is different from the rest of the circulation. Because in coronary arteries, the filling is during diastole. In the other circuits, the blood is pumped through the heart and passes through the arteries during the phase of systole. But in coronary arteries, it is the diastolic phase in which there is coronary filling. When the myocardium contracts forcefully during systole to eject the blood, the myocardium compresses the coronary arteries and the blood is not passed through the coronary arteries. So during the systolic phase, the myocardium is relatively ischemic. And when there is diastole, the blood regurgitates back towards the left ventricle, the aortic valve closes, and the aortic cusps, the sinuses behind the aortic cusps, they open and the blood flows through those cusps into the coronary arteries. So one important feature is that coronary circulation is diastolic. Coronary filling is diastolic. It is not systolic. Number two, it is heart rate dependent. We can see, if you see the cardiac cycle, there are two phases, a systole and a diastole. Systole is a relatively fixed period. It does not vary with heart rate. If it is tachycardia or bradycardia, the systole nearly remains the same. The cardiac cycle length changes by change in the diastole. When there is tachycardia, the diastole becomes smaller. When there is bradycardia, the diastole becomes a little longer. So when there is tachycardia, for whatever reason, for example, patient exerts, a patient is doing an exercise, patient is excited, or you have given some drug which causes tachycardia, so there will be a diminished period of diastole. So that means that coronary filling in the diastole will decrease as will decrease in cases of tachycardia. So anything which increases the heart rate is going to cause a decrease in diastolic period, and hence the diastolic filling of the coronaries will be less. So these two are the peculiar features which we do not see in other type of circulation. When there is tachycardia, the circulation to other organs starts increasing. But in case of heart, the circulation or circulatory flow starts decreasing, so blood supply starts decreasing. So that is one important feature. Now, what particular problem causes this demand and supply mismatch in addition to this condition? You see, in a normal physiologically functioning heart, this does not really produce a problem. The patients, the normal people who have tachycardia during their exercise or they're excited, this does not produce a demand and supply mismatch. What causes the most important thing is the atherosclerotic cardiovascular disease. What happens in atherosclerosis? The lipids, they start depositing in the intima of the coronary arteries, and with the advancing age, this deposition starts increasing, and you can see this ultimately starts compromising the lumen of the coronary arteries. When the lumen or occlusion exceeds certain critical phase, the patient starts having these symptoms of demand and supply mismatch. So basically the most important thing underlying the ischemic heart disease is atherosclerotic process. There are other problems as well, but this is nearly, you can say, nearly in almost all cases, this is atherosclerotic cardiovascular disease which produces this ischemic heart disease or the demand and supply mismatch. And the patient has symptoms because of this demand and supply mismatch. We will see what happens when this demand and supply mismatch occurs. Now, what are the risk factors which produce this atherosclerotic cardiovascular disease? There are conventional and non-conventional risk factors. The conventional risk factors are which were identified during the Framingham study. So they can be divided into non-modifiable and modifiable. Non-modifiable are age. With the increasing age, the prevalence and incidence of ischemic heart disease starts increasing. The fatty streaks, which are present right from the beginning of human development, they start having these deposits of lipids as the age advances. So you can see the disease is more common in advancing age. Sex, there is some difference in the sexual prevalence of ischemic heart disease. You see, in premenopausal women, the prevalence of ischemic heart disease is far less than the males. So in those ages, especially before the age of 55, it's a predominantly disease of males. But as after menopause, the prevalence in the female starts increasing, and ultimately it reaches the prevalence of this disease as is seen in the males. And then family history. You cannot change the family history. If you've got a family history, this is one very single important predictor that an individual might suffer from ischemic heart disease. So these are non-modifiable. You cannot modify these factors. And now you've got certain modifiable factors. For example, one important is hypertension. If you see, hypertension is one of the leading causes which contributes to cardiovascular mortality. So hypertension can be modified. Similarly, diabetes is type 2 diabetes. Most important, type 1 diabetes in the long term can also produce ischemic heart disease, but it is type 2 diabetes, which sometimes is present when myocardial infarction is first seen, or sometimes you see diabetic patients and you investigate them and you find that there is concomitant ischemic heart disease also going on. So this is called diabetes, type 2 diabetes mellitus is also called ischemic heart disease equivalent. So it means if a patient has a type 2 diabetes, him or her having a chance of an MI is similar and comparable to a person who had MI previously and was not diabetic. So this is again a very strong risk factor which can be managed. Smoking. Smoking is also one of the major risk factors which contributes to ischemic heart disease. You see these four: dyslipidemia, smoking, diabetes mellitus, and hypertension. These are the four most important modifiable risk factors which contribute to the ischemic heart disease. So any patient who is smoking should be counseled because smoking contributes a lot to the ischemic heart disease, and we quantify smoking into pack years. If a person smokes 20 cigarettes a day, it's for 1 year, this is called 1 pack year. So when you see smoking, you quantify into the pack years. If a person smokes 40 cigarettes a day for 1 year, this will be 2 pack years. Similarly, if a patient smokes 10 cigarettes per day for 2 years, this will be 1 pack year. So we quantify how much the patient is smoking, and then dyslipidemia. Dyslipidemia, if the patient has abnormal lipid profile, what abnormality in the lipid profile predisposes to the development of ischemic heart disease? One important thing is the increase in the LDL cholesterol, and the second thing is lower HDL cholesterol. These two, if the combination of this is present, this is very serious risk factor which can contribute to the development of this or the deposition of this lipid material or cholesterol material into the intimas of the coronary arteries. And then you've got some other risk factors like personality type. Patients who have got a very competitive and aggressive personality, they are anxious people and they are very competitive. They tend to have more of this disease. Patients who are obese or patients who have a sedentary lifestyle, they tend to develop more of a coronary artery disease when compared to the person of same age, sex and weight if they have a different lifestyle. So the disease is more in patients who've got a sedentary habits, those who are obese, or those who have a competitive or type A personality type. And then you see with the development in the technologies and our information, we found certain other factors which are also contributing, or at least they tell us that if these factors are present, the underlying ischemic heart disease should be looked for. For example, ankle brachial index. If the blood flow of ankle arteries and the brachial arteries, they are compared. If the ratio is abnormal, if this is less than 0.4, it means it's quite abnormal, and the patient will have symptoms of peripheral arterial disease. If the patient has peripheral arterial disease, chances of having coronary artery disease are very much increased. Similarly, if there is left ventricular hypertrophy, if there is metabolic syndrome is a combination of insulin resistance, hypertension, dyslipidemia, central obesity, and there may be type 2 diabetes, or there may be, in fact, fatty liver as well. So these patients are suffering from metabolic syndrome. They tend to have more of ischemic heart disease. And then patients who've got microalbuminuria in the kidneys are excreting small amounts of proteins. These are at high risk of developing ischemic heart disease. Similarly, patients who've got homocysteine or they are suffering from any chronic inflammation, they are also at an increased risk of ischemic heart disease or coronary artery disease. And then finally, if you do a CT scan on the coronary arteries and you find out that there is a high calcium scoring in the coronary arteries, this may be an indicator that there is underlying coronary artery disease. Now, when there is a demand and supply mismatch, what happens? When the myocardium is contracting, it requires more and more oxygen. When the oxygen supply diminishes, the patient starts having symptoms. Now, we classify those symptoms into different types of coronary syndromes. One of them is chronic stable angina, the other one is acute coronary syndrome. Now, chronic stable angina is the patient has symptoms for a very long time. They are related to exertion, and if the patient is not exerting, the symptoms tend to settle down. Now, acute coronary syndrome is a different proposition. Patient may be having symptoms even at rest. So we divide this into unstable angina, non-ST elevation MI, and ST elevation MI. You see, if there are recurrent episodes of non-ST elevation MI or ST elevation MI, they can lead to ischemic cardiomyopathy. That means there is a weakening of the left ventricular muscle mass. Now, what is unstable angina? Unstable angina is the patient has symptoms of ischemic heart disease which are present at rest, or which are of recent onset, or which occur after myocardial infarction, or if the patient has the symptoms on minimal activity. This is called unstable angina. Now, we differentiate unstable angina from these two conditions is that in unstable angina, there is no necrosis of the myocardium, while in these two conditions, there is necrosis of the myocardium. Certain portion of the myocardium becomes dead, while in this, there is no necrosis of the myocardium. Now, what is the difference between NSTEMI and STEMI? STEMI is ST elevation MI, and this is non-ST elevation MI. Non-ST elevation MI means partial thickness infarction. If you got a myocardium which is this thick, if you have an infarction of this portion, partial thickness, usually this is subendocardial. So this is called non-ST elevation MI, and when we see changes on the ECG, we see that the ST elevations are not, their ST segments are not elevated. The patient may have T wave inversions, or they may be ST segment depressions. And if the patient has a full thickness MI, through and through MI, this is called STEMI. That is ST elevation MI, and there is full thickness myocardial infarction. And in these two conditions, we find the evidence of myocardial necrosis. As, for example, if we do cardiac enzyme testing, we find the cardiac enzymes are abnormal, but in unstable angina, the cardiac enzymes are not abnormal. So these are the two different conditions of acute coronary syndrome, this unstable angina, or this myocardial infarction. Myocardial infarction can be full thickness, or it can be partial thickness. And if there are repeated episodes of this infarctive process, the myocardium becomes weak and the pump function of the heart starts diminishing and ultimately leads to heart failure. So this is called ischemic cardiomyopathy. As I mentioned, chronic stable angina is a disease in which the patient has symptoms going on for a very long time. And now we see what are the clinical features, the history and the physical examination, and then we will see how to investigate chronic stable angina. Now, the most important history of, or the symptoms of chronic stable angina is the chest pain. Patient comes with chest pain. Now, to evaluate chest pain, you have to see what is the site, how is it radiating, what is the character of the pain, what are the aggravating or relieving factors. So this is the main important symptom of chronic stable angina. And then some patient may complain of shortness of breath, and then when you take the history, you have to assess for the presence of risk factor. For example, if the patient is diabetic, hypertensive, if the patient smokes, or if the patient has a family history of ischemic heart disease. So you have to evaluate the presence of risk factors. Now we concentrate more on what is the main symptom, the chest pain. Now sight. You know there's a difference between somatic and splanchnic pains or the visceral pains. Visceral pains are generally poorly localized because there are very few nerves which travel from the viscera to the central nervous system, and these nerves are supplying the sensory information from these different organs. So when we see patients who got visceral pain, they tend to have a diffuse and very ill-localized pain, while in patients who've got somatic pain, they have a very sharp and localizing pain. If the patient has a pain in, for example, in the chest muscle, the patient can even pinpoint that this is the area I'm having pain. Now the pain of chronic stable angina is usually central. The patient complains that there is a pain in this region, and the patient does not usually put in a finger that the pain is here. If the patient is localizing the pain very well, then it's a possibility of having ischemic heart disease is very low. The patient just tends to have a pain which is present in this area. So it is usually in the center, maybe it's a little more on the left side, but the patient actually cannot say that this is here or here. The patient just puts in a hand in front of the chest and says, that's something, some problem I feel here, the pain is in this area. Now this pain can radiate to multiple areas. It can radiate up into the throat and into the lower jaw. It can radiate to the left shoulder. It can radiate to the left arm, usually inside of the arm. It can radiate even to the right shoulder. It can radiate to the epigastrium. The inferior wall pains, they radiate to the epigastrium, and sometimes they're confused with abdominal pathologies, for example, a peptic ulcer disease or reflux disease. And the patient's pain can also radiate to the interscapular area. So these are the different radiation. Now, another important feature is what is the character of the pain. The character of the pain is generally, it is moderate to severe intensity pain. Patient describes that there is something which is pressing the chest as if it is being crushed in some claws. So this is what's the description. The patient says, somebody has just put on a lot of weight on my chest. So this is the character of the pain. And you see, angina pectoris means a vice in which you can grasp things and grip things, and pectoris means chest. So there is a gripping or crushing pain in the chest. Now this pain is aggravated by maneuvers which increase heart rate. For example, if the patient starts exercising, a patient starts walking, and after some time, as the heart rate starts increasing and the critical level is achieved, the patient starts having symptoms. Or if the patient is excited, if the patient is anxious, if the patient is excited for whatever reason, the symptoms may start coming in. And the classical feature of angina is that usually it is after a certain specified distance which is different for every individual. And if the patient has taken a meal, this pain may come at a distance less than what is usual for that patient. Or if the patient is walking uphill, or if the patient is walking against cold wind, the patient may have pain which comes earlier than routine. And what is the relieving factor? The relieving factor is that patient sits and relaxes and the pain starts going away. Or if the patient puts sublingual nitrate tablets or glycerol trinitrate under the tongue, the pain starts improving. So these are the different aggravating and relieving factors. Now, another symptom is shortness of breath, which may develop in some patients. For example, if during episode of angina, the papillary muscle of the myocardium, they start malfunctioning, the patient may have slight bit of mitral regurgitation that may precipitate shortness of breath. But this shortness of breath disappears when the patient sits down. And if we do an echo in the resting phase, we do not find that there is active mitral regurgitation. So this is that some patients, they experience shortness of breath as well. Most of the patients, they experience pain and a choking sensation, while some of them may also experience, in addition to this, shortness of breath. And then you assess for the presence of risk factor, as I mentioned, check for the presence of diabetes in the history, the family history, the presence of hypertension, the smoking, if the patient has ever been tested for dyslipidemias, if these are present. So you also take note of these risk factors which may be present. And then we come to the physical examination. The physical examination may be unremarkable. When you examine the patient, may be normal. If the patient has symptoms, you may find the patient may have tachycardia, or there may be few abnormal murmurs, as I mentioned. The patient may have a murmur of mitral regurgitation. But generally, when we examine the patient of chronic stable angina, as far as heart is concerned, we generally find that this is normal. So the physical examination may be normal. You look for the presence of risk factors. Look for the presence of hypertension. You measure the blood pressure. Look for the presence of hypertensive retinal changes, if they are present or not. If the hypertension was not discovered on history, so you examine the optic fundi and see there is any evidence of hypertensive retinal disease. If there is evidence of hypertensive retinal disease, there will be a hypertension going on. Similarly, you can see in the retina, the optic fundi, the diabetic changes. And then you can see for the presence of dyslipidemia, there may be tendon xanthomas or xanthelasmas which may be present, which are usually present near the tendons and usually on the extensor surfaces. You can see xanthelasma around the eyes. If there is a premature arcus present in the cornea, that may be a clue that this patient is having lipid abnormalities. So you look for the presence of evidence of smoking, which can be seen from the staining of the nicotine staining of the nails. So look for the evidence of diseases which might be contributing to the development of ischemic heart disease. And then you should look also for the presence of contributing factors. For example, if the patient develops anemia, this mismatch comes earlier. So look for the presence of anemia or thyrotoxicosis. Thyroid disease, if it is patient is thyrotoxic, it causes tachycardia, and tachycardia can precipitate ischemic heart disease. Similarly, in hypothyroid patients, if there is hypothyroidism, there may be dyslipidemia that would be contributing to the development of ischemic heart disease. So when you examine, this is what you do. And now, what are the differential diagnosis of this pain? You see, this is a central chest pain, which is diffuse and ill-localized. One of the most important differential of this thing is esophageal disease. Esophageal. That is GERD, gastroesophageal reflux disease, and diffuse esophageal spasm. Diffuse esophageal spasm. And other motility disorders of esophagus, for example, achalasia, can also produce similar symptoms. Then if the patient has in the central, if you look at the center, the other major organ is the aorta. If there is a dissection of aorta, it can produce pain. The pain of esophageal spasm is sometimes so much confused with the pain of ischemic heart disease that at times you have to differentiate it through the angiography. And then aortic dissection is a very serious occurring. And this is a sudden onset tearing pain which starts in the center, may go up and back into the interscapular region. And you examine, you may find that there are differential pulses, that one of the pulse may be weak, one may be, or there may be difference in the blood pressure in the two arms, or there may be a difference in the palpation when you see two carotid arteries if the dissection has gone upward. If it goes into the subclavian arteries, you have a difference in blood pressure. If it goes into the carotid, you may find that there is abnormal pressure in both carotid pulses. And then this central pain can come from trachea. If there is tracheitis, you can have that pain, but that pain usually is experienced with coughing. So it has association with respiratory phenomena. So these are the major differential for a pain which is present in the center. And then you can have pain which is coming from the abdomen, as I mentioned, that the pain may radiate down into the epigastrium. So if you've got epigastric pain, the differentials include again the reflux disease, the peptic ulcer disease, the gallbladder disease, or sometimes pancreatitis. So you have to differentiate if the patient is having other abdominal symptoms, and if these symptoms are present along with other GI symptoms. The patient may be having diseases below the diaphragm. And then you have got pleural diseases which can mimic ischemic heart disease, especially if the pleuritis is on the left side. But one important feature of pleuritis is that it does not cross midline. The parietal pleura is supplied by the somatic nerves which do not cross the midline. The patient will complain of pain which is hemithoracic. If it is crossing the midline, most likely this is not from the parietal pleura. And the second thing is this pleural pain has association with the respiratory phenomena. For example, patient coughs or sneezes, the pain increases. Similarly, the pain of musculoskeletal origin or pain which is arising from the spinal structure. For example, if there are nerves which is coming out of the spine, if they are afflicted, for example, in herpes, so they may also show a respiratory phenomena. And again, these pains do not cross the midline. They remain on one side. They are hemithoracic in nature. While the pain of central structures like heart, the esophagus, the trachea, they're in the center and may be felt on both sides. So this is how we differentiate the pains of different organs, which may be mimicked with the pain of ischemic heart disease or chronic stable angina. But you see, again, the most important feature of chronic stable angina is that patient has symptoms which is related with maneuvers which increase heart rate. For example, patient starts exercising or patient is excited. So that may precipitate angina, and the patient rests or takes sublingual nitrate, the pain starts disappearing. And in this connection, one thing is also to be remembered that sometimes the pain of diffuse esophageal spasm also is relieved with sublingual nitrate, because certain portion of the esophagus has smooth muscle. The upper portion has skeletal muscle, lower portion has smooth muscle. If there is spasm in that smooth muscle which produces central pain, and if you give sublingual nitrates, they cause relaxation of the smooth muscle as well. So the patient may have improvement in the esophageal pain because of the nitrate. So that's why the pain of diffuse esophageal spasm has the most important differential of chronic stable angina, because they are very similar sometimes and difficult to differentiate. So when we investigate the patients who are suffering from chronic stable angina, first we do some general investigations. By general investigation we mean we check for the presence of diabetes. You can do a spot blood sugar, or you can do hemoglobin A1C testing to see if the patient is diabetic, if already not known. And then you can also go for patient's lipid panel. How is the lipid profile? So fasting lipid profile will help us to see if the dyslipidemia is present. And in some patients, you should also look for the presence of anemia and thyroid disorders. The hyperthyroidism and hypothyroidism both can produce problems. So a thyroid status can be tested. Similarly, patients who are having chronic inflammation, we can see highly sensitive CRP, that can be done. Similarly, we can also do in some patient homocysteine level to find out if there is abnormal homocysteine. So these are general investigation. In addition, you can go for urine for microalbuminuria, the renal function testing, the liver function testing, if there are any concomitant illnesses going on. And then when we come to specifically the investigation for the angina, first we do is the resting ECG. The resting ECG may be normal in between the attacks, and it may sometimes be normal even during the attack. So it does not really help us. If this ECG is abnormal, then it can help us. The catch in the ECG is that we should do a serial ECG. If there is a change in the ECG that is more significant than a fixed defect which is seen on ECG. What we see during the episode of angina is ST segment depression and T wave inversions. So these may be visible on ECG. And there may be evidence of previous myocardial infarction. If the patient has previous coronary artery disease, patient had an MI earlier, so the features of that MI may still be present in the ECG. So this is what we find from the resting ECG. And more important test is the exercise tolerance or treadmill testing, that we put the patient on graded exercise and see what's the response, and during that we monitor patient's ECG and see if there is change in the ECG. So we usually follow a treadmill for this exercise tolerance testing. In treadmill, the Bruce protocol is what is usually followed. In this protocol, after every 3 minutes, the incline and the speed of the treadmill changes, and hence the resistance against which patient has to walk starts increasing, and we see during that procedure what are the changes in ECG or what are the symptoms of the patients. If the patients develop ST segment depression of more than 1 millimeter, measured 80 milliseconds after the J point, this is significant. Or if the patient starts having characteristic pain, we stop the test and this test is labeled as positive. Now, what are the problems with this test? Some of the patients cannot do exercise tolerance simply because of the physical limitation. They may have a knee problem, they may have a back problem, or they have a respiratory illness because of which it is not difficult for them to walk. Or if the patients are very obese and they are unable to manage a treadmill. So in those cases, it cannot be done. On medical grounds, if the patient has symptomatic aortic stenosis, this test is relatively contraindicated. Similarly, if the patient has unstable angina, that means the patient has symptom on minimal exertion, this test should not be performed. Now, what are the indications or uses of this test? Number one, it is used to confirm the diagnosis of chronic stable angina if it is not diagnosed on history. So this is the first test we do. And then it determines the severity of limitation. From this we can find out the effect of ischemic heart disease on the patient's daily living. How much is the daily activity limited by this disease? Then we can assess the prognosis in patients who are carrying the coronary artery disease, or even the patients who are recovering from myocardial infarction. We do a treadmill test at 4 weeks and assess what is the prognosis. And then we can also evaluate the response to treatment. For example, if a bypass procedure has been done on the patient or a PCI has been done on a patient who had chronic stable angina, and we see has the exercise capacity of the patient increased or not. So this test is used for this purpose. And then we can do radionuclide studies. We inject radio-labeled substances into the patient's circulation, and this radionuclide uptake is proportional to the blood supply in the coronaries at the time of injection. So if the blood supply is normal, the uptake will be high. If the blood supply is compromised, the uptake may be low. Now, these radionuclide studies are good. They can be done when the resting ECG is abnormal. For example, if the patient has left bundle branch block, or if the patient has pre-existing ST depression or ST elevation, it may not be possible to assess this on treadmill because this resting abnormal ECG may be difficult to interpret on the treadmill. So we can go for this radionuclide studies. Confirmation of ETT findings, especially if the patient is asymptomatic and you find out that the ETT is positive. And this treadmill shows that the patient has disease while the patient does not have any symptoms. So we can go for this radionuclide study. The radionuclide studies can very nicely localize the region of the heart which is affected. So you can see the localization of the disease, which is sometimes not possible with exercise tolerance test. The nuclear studies can differentiate between ischemic myocardium from that of infarcted myocardium. When there is ischemia, you inject the drug, and the imaging shows that there is a poor uptake of that drug in that particular area, and we give the patient rest and retake the images. And if in these delayed images that perfusion defect improves, that means that was only ischemic myocardium, not infarcted myocardium. In infarcted myocardium, that defect will persist, or we call that a cold area. That cold area will persist. Then you assess the intervention. If a PCI or a CABG has been done, that is the bypass operation has been done, you see the effectiveness of that operation. And similarly, we can assess the prognosis from this. Because radionuclide imaging not only tells us the uptake of the radionuclide, it also tells us the functioning of the LV, and we can sometimes also calculate the cardiac output. So this helps us in assessing the prognosis of the disease as well. And then the next imaging investigation is echocardiography. We do a stress echocardiography in cases of chronic stable angina, because echocardiography between the attacks may be quite normal. So we do give the patient stress, either it's stress of an exercise or a pharmacological stress. Patient is given a supine or vertical exercise depending upon the patient's condition, and or you can give a pharmacological stress. And during this patient stress period, the examiner goes for an echocardiographic examination to see if the echo findings becomes abnormal. The abnormal findings usually are that there is abnormalities in this myocardial wall contraction. So that may be visible on echo. If this becomes normal on resting again, so this confirms our impression that the patient has a reversible ischemia in that region that caused malfunction in the contraction of that part of the myocardium. And then we can do CT angiogram. The multi-slice CT technology helps us in making images of the heart. With the software, we can also construct the image of the coronary arteries, and we can image the LV cavity as well. So this helps us in making a coronary angiogram. This is called a CT coronary angiogram. And similarly, with the CT scan, we can do calcium scoring. We can find out how much calcium is deposited in the plaques. This helps us in assessing that the patient might have ischemic heart disease and what is the burden of plaques in these patients. Now, in some patients, we go for coronary angiography. Coronary angiography is that through the brachial artery or the femoral artery, we pass in a catheter, and we guide this catheter into the coronary arteries and inject the dyes and take the picture of those coronary arteries. This is the gold standard test in imaging the coronary arteries. Now, why do we do angiography? If the patient has life-limiting stable angina, if it is very severe, the patient has very limited physical activity, and this may cause severe compromise in patient's quality of life, we go for coronary angiography, because the coronary angiography not only tells us what is the burden of the disease, what is the site of the disease, what is the severity of the disease, it can also provide us with the opportunity of manipulation at the same time. Patients who've got high-risk disease, for example, our assessment is that patient may be having a high risk. How we define this high risk is we do a pre-test probability calculation. Pre-test probability. What is a pre-test probability? Pre-test probability is that from our basic data, that is history, physical examination, and basic investigation, we find out what is the possibility of this patient having a particular disease. For example, in case of ischemic heart disease, if the patient has a family history, patient has dyslipidemia, or is a smoker, or patient is hypertensive or diabetic, and patient gives us symptoms which are quite suggestive that this may be ischemic heart disease, and if the patient's symptoms are so severe that they are life-limiting, and there's a very high chance that the underlying disease is ischemic heart disease, we go for this invasive investigations. If there is low pretest probability or there is intermediate pretest probability, we may be following this algorithm. But if the patient has a high pretest probability, we may go straight to coronary angiogram. If the patient has concomitant aortic valve disease, or if the patient is asymptomatic in old age and is undergoing valve surgery, so we do an angiogram to see if the coronary arteries are normal or not. If there is a disease in the coronary arteries, the patient can be managed at the same time. When the valve is being replaced, a coronary intervention can also be done. If the patient has symptom recurrence after intervention, if you've done a PCI or if a CABG has been done, if the patient starts having symptoms again, a coronary angiography is warranted. Patients who've got cardiac failure, we do an angiogram to see if there is a viable myocardium present, if there is a myocardium which can be salvaged so that the cardiac failure worsening can be prevented. If that viable myocardium can be saved, the cardiac function can be preserved. So this is one indication for doing a coronary angiogram. Then survivors of sudden cardiac death, those who have got sudden cardiac death, a CPR was done and they were revived. In those patients, angiography is usually done because these are very high risk patients. And then if a patient has a pain of chest pain of uncertain etiology, we go for an angiography to clearly differentiate this is esophageal pain, this is pain of coronary artery disease, or this is a pain of some other pathology. And then patients who've got acute coronary syndrome, when they reach early in the hospital setting and we want to do a PCI, in these patients we would like to do an angiogram. Now the angiogram, as I mentioned, tells us the presence of disease, the severity of the disease, the site of the disease, and sometimes the angiogram is normal and the patient has symptoms. What are those conditions? We call them ischemic heart disease with normal coronary arteries. This is seen in patients who have got aortic stenosis. Patients who have got syndrome X. And patients who have taken some drugs which cause vasospasm. Or another one is vasospastic angina. So if a patient on angiography turns out to be normal, this usually happens in aortic stenosis when the intraventricular pressures are very high and they cause severe compression of the coronary arteries and the coronaries remain ischemic, and when the patient goes for an exercise, the symptoms are precipitated. Similarly, syndrome X is a condition in which the coronary arteries are normal. Patient has problems at the microvascular level. The small vessels are affected and the symptoms are exactly like chronic stable angina, but the coronary angiogram is normal. The other tests may show abnormalities. For example, there may be abnormality on the ECG, or there may be abnormalities on the echo, but the treadmill testing or the angiography is normal. Similarly, some of the drugs they can produce, for example, cocaine causes vasoconstriction. So when you do an angiogram, you find out the angiography is normal. So these are the different investigations we conduct for the patients of chronic stable angina. Now we'll see what treatment we can offer to these patients. So now the treatment of chronic stable angina. You see, the problem was demand and supply mismatch. If we can improve that mismatch, the symptoms can improve. Now there are multiple strategies which we use to control this patient with chronic stable angina. Unfortunately, we do not have a lot of armamentarium to control the progress of the disease. So there are only few things which we can help to retard the progress of this lesion towards this stage. Now, first thing is risk factor modification. Control of blood sugar is extremely important, but how much control? You see, studies have shown too tight a blood sugar control. For example, if we bring the hemoglobin A1C less than 6.5, this is counterproductive. So we need an optimal blood sugar control. The blood pressure control should be really tight. The targets are usually not exceeding 130 or 80. The blood pressure should be controlled, and any drugs which are used for blood pressure can be prescribed, and until and unless there is some particular contraindication. Then third thing is dyslipidemia. There is need of aggressive lipid management, and you can find the guidelines of different forum which are used to control the lipid levels. And then cessation of cigarette smoking. Improving the lifestyle, that is daily physical activity, that's 30 minutes of brisk walking 5 times a week should be encouraged, and the patient should be encouraged to lose weight. Control of aggravating factors. For example, stress aggravates, and if it can be managed, can be quite useful. Similarly, extremes of temperature, very hot and very cold temperature, can precipitate angina. So patient can be advised to manage these aggravating factors. Anemia can be addressed. If the patient is anemic, find out the reason for anemia and, if possible, correct it. Otherwise, patient can be given supplemental transfusions. Thyroid problem, if it is there, it can be controlled with drugs very effectively. So first thing is that we should go for risk factor modification and control of aggravating factor. Now we come to the drugs which improve the patient's symptom in ischemic heart disease or chronic stable angina, and the drugs which can decrease the incidence or new onset of acute coronary syndromes or the cardiac events. Now the first drug we choose is nitrates. Nitrates are used for symptomatic improvement. They can improve the pain and they can somewhat increase the patient's exercise tolerance. Sublingual nitroglycerin or nitrates can be used just 5 minutes before the planned activity, so they can improve the patient's walking distance. 0.3 to 0.6 milligram of sublingual nitroglycerin can be used, or a spray is available, a translingual spray can also be used. And then we can use these long-acting nitrates, these isosorbide mononitrate, isosorbide dinitrates, which can be used as tablets. But the problem with the long-acting nitrates is that the patient develops tolerance, and there should be a nitrate-free interval daily. So a patient should be nitrate-free for 10 to 12 hours so that they remain effective. Another problem with nitrates is they cause, in some patients, intolerable headache. So these are good drugs which provide symptomatic improvement. And then you've got beta blockers. Beta blockers is probably one of the most important drugs which is used in chronic stable angina. And a lot of studies have shown that beta blockers in ischemic heart disease, post-MI, they decrease mortality. So the beta blockers are the next line of drugs which are used for chronic stable angina. And those can be calculated to bring the heart rate to around 60 beats per minute. The beta blockers with intrinsic sympathomimetic activity, just like pindolol, they should not be used, because when there is intrinsic sympathomimetic activity, that means the heart rate will increase and a force of contraction will increase. So that will worsen this mismatch. So the beta blockers without intrinsic sympathomimetic activity can be used. Cardioselective beta blockers are better because of their tolerability profile. So you can use metoprolol, you can use carvedilol, you can use bisoprolol and nebivolol. And then the next drug is ranolazine. Ranolazine is a different class of drug which is neither a beta blocker, neither it affects the heart rate or nor the force of contraction, but studies have shown that it improves the patient's symptoms of angina. One problem with ranolazine is that it should not be used with the drugs which increase the QT interval, because it itself increases the QT intervals. So it can be combined with other anti-anginal drugs. For example, it can be combined with beta blockers or even with calcium channel blockers. Now the next class of drug is calcium channel blockers. There are two types of basically calcium channel blockers, dihydropyridine and non-dihydropyridine. So the dihydropyridine beta blockers, for example, nifedipine, that resulted in increased mortality post-MI, so they should not be used. But in cases of angina, they can be used as second-line drugs if the patient cannot tolerate beta blocker or beta blockers are contraindicated. So in those patients, calcium channel blockers can be used. Both diltiazem, verapamil can be used for this purpose. So then the next class of drug is ivabradine. Ivabradine is a drug which works on the funny channel present in the SA node. It decreases the heart rate and improves the angina. This can also be combined with other drugs. And then you've got another important class of drugs. These are we call them blood thinners. Major among these blood thinners are the platelet inhibitors, and then you've got an anticoagulant drug, that is rivaroxaban, which is a different class of drugs. But I have grouped this into platelet inhibitors because these drugs, they are basically blood thinners. So aspirin is the drug of choice if the patient has no contraindication. It is seen in multiple trials that aspirin, not only in post-infarction but in patients who've got chronic stable angina, provides real benefit of preventing the onset of new events. Clopidogrel can be used in patients who cannot tolerate aspirin or they are non-responding to aspirin. So clopidogrel is one of the drugs which can be used instead. And then ticagrelor is another drug which is another antiplatelet drug, and it can be used especially in patients who've got acute coronary syndrome or if they've gone for revascularization. So this drug can be used. And another drug, vorapexor, is a drug which is recently approved by the FDA for to be used as an antiplatelet drug in patients who've got MI or peripheral vascular disease. This drug is contraindicated in patients who've got stroke, TIAs, or they've got intracranial events. So it's not to be used. Rivaroxaban is factor Xa inhibitor, which is an anticoagulant. Low doses of rivaroxaban combined with aspirin have produced useful effects. 2.5 milligram twice a day combined with aspirin has beneficial effects in patients who've got chronic stable angina. Now, these two are the, again, symptomatic treatment modalities. One of the extracorporeal counterpulsation, that if in the lower half of the body we use pressure chambers which can increase the pressure in the lower half of the body, which improves the venous return, especially during the diastolic phase. So it can improve coronary circulation if it's done for 7 weeks. It provides symptomatic improvement but does not affect the course of the disease. Similarly, patients whose pain is not being controlled and is very bothersome and they are not candidates for other type of treatments, and neuromodulation through spinal cord manipulation with different stimulators can be used to control the pain. And then finally we come to the revascularization procedure. Revascularization in chronic stable angina is only done if the benefits of revascularization outweigh its risks or its advantages. Patients, the multiple trials have shown patients who've got low to moderate disease, in those patients the maximal anti-anginal treatment which we use provides results as good as those provided by the revascularization procedures. So revascularization procedures are only indicated in patients who have got severe disease. Of the revascularization procedures, we can use either PCI, the percutaneous intervention, or the coronary artery bypass grafting. Percutaneous intervention means we do an angiogram, we dilate the obstructed lesion with a balloon, that's called angioplasty, and then we can place a stent in it. And CABG, that we provide an alternative blood vessel. That can be internal memory artery or a venous graft taken from the lower limbs and placed across that bypass. So in what patients we should go for these revascularization procedures? In patients who have got unacceptable symptoms despite maximum medical therapy. If we are using all these drugs in different combinations and the patient is not having improvement in the symptoms, one should go for revascularization procedures. Patients who have got left main stem disease with an obstruction of 50% or more, which is with or without symptom. So if you remember the coronary circulation, you have got left coronary artery, right coronary artery. Left coronary artery divides into anterior descending and circumflex artery. If the left main stem has an obstruction of 50% or more, and it is present with or without symptom, these patients should go for a revascularization procedure. In patients who've got left anterior descending artery, which is more than 90% obstructed, and the patient has LV dysfunction, those patients should also undergo revascularization procedures. If a patient has a 3-vessel disease, or called triple vessel disease with LV systolic dysfunction, these patients are again a candidate for bypass or revascularization procedures. Patients who got unstable angina, or patients who get angina which is post myocardial infarction, these patients are again candidate for revascularization procedure. And the last, we mentioned that patients who got acute coronary syndrome, they are again candidates for revascularization procedure, preferably PCI in patients who got acute coronary syndrome. But in these different type of condition, we can choose between these two modalities depending upon the situation of the patient, the availability of the facilities, and the acceptability of the patient. So we can choose between these things. So these are the treatment modalities which are used for chronic stable angina. And again, to emphasize the important thing, that risk factor modification and control of aggravating factors. This should always be discussed with the patient and should be addressed very aggressively, because all these treatments which I have mentioned do not affect this process. This process, if at all, is affected by risk factor modification, because these are the reason this lesion is developing. So the patient should be focused on this risk factor modification, and you can, if possible, control the aggravating factors. Now in our next lecture, we will discuss the acute coronary syndromes. Till then, goodbye.